Before we get started, I'd like to read the disclaimer on your screen. The Pharmacist Virtual Learning Experience, brought to you by Mandell's Clinical Pharmacy, is intended only as an educational program for patients. Any clinic-specific information shared by the nurses is the opinion of the nurse and is not intended to replace the recommendations or requests of your healthcare professionals. All medications will be dispensed by Mandell's Clinical Pharmacy according to the prescription as written by the provider.
I'd like to talk with you about administering Minipure. If your prescriber has recommended that you take Minipure, it's given subcutaneously, which means in the fatty part of your skin. You can either generally give it in your lower abdomen or in your outer thigh. It's quite easy to mix it. It does take a few steps though. You need to start by taking a look at what your dosage is. Each bottle of the powder of Minipure contains 75 international units. So if you have been prescribed 150 units, you will need 2 vials of the powder. No matter how many vials of powder you'll still just use 1 cc of the liquid. So I like to start by opening up the tops from all of the bottles. So we're going to do a demonstration today for 150 units. So you'll need again 2 powders, and you just lift the top up of the vial of both powders. It actually just lifts up really easily. And then lift off the top of one of the liquids. The liquids are just a way to dissolve the powder. There's no medication in here. It's important you use this liquid, but don't worry, you'll probably have some liquids left over. The next step is to take a Q cap. You may not have ever seen one of these before, but you just open up the package, and there's a little device that's in here that will just slip right onto the top of the ampule of the vial. So take the vial of liquid and just snap the Q cap right on top, just like that. Next, you'll take a syringe that will be provided with your medications, and it just screws right on top of the Q cap. Then the pretty cool part begins. Just draw back about a cc of liquid. If you get some air in there, that's okay. We'll have plenty of time to get that out. Once you get the liquid into the syringe, take off the syringe and the Q cap as 1 unit, and that has all of the liquid that you'll need. Next, you'll take the first vial of powder, attach the Q cap, squirt in all of the liquid, swirl it around a little bit, but it dissolves very quickly. Turn it upside down and withdraw that mixture. Now you have 75 units in the liquid in the syringe. Then take the Q cap and the syringe off as a single unit again, and put it on to the second powder. And it just snaps right on. Squirt in the liquid, swirl it around a little bit to make sure it's all dissolved, and then draw up that mixture. After that's in there, you have both of the ampules of powder, the vials of powder, in the syringe. Just unscrew it, and you're ready to put a needle on the top of it. And you can just take the tiny little needle right out of the package, and similarly, it'll just screw right on the tip of the syringe. And it's ready to give. When you give this injection, you might first want to take an alcohol pad and just swab the area that you want to give the injection. Then take the needle off, take the cup off the needle, bunch up the tissue, insert the needle straight in all the way, and then just push the medicine in. Release the plunger, wait a couple seconds, pull the needle straight out. If you need to, you can wipe the area with the alcohol prep and apply a bandage if you have a little bit of bleeding. But just like that, you've given your injection of Menopur. So how easy was that? You can just take out all the supplies when it's time to do your injection, and you can just mix it right along with me. So it's quite simple to do, just a few steps to do. The first time you do it will be the hardest time, just because it's different, and you're gonna just want to make sure you don't make mistakes. And how is it going to feel putting the needle through the stopper of each vial? But after you've done it once, you'll be ready to teach the other ladies in the waiting room how to do it. So let's start out by asking hearing what questions y'all have, and then we'll have a little more discussion. Craig, do we have some questions?
Yes, we do. How's it going, Karen? All right.
Going great.
So we
Good to
have
see
a
you.
couple of questions. Good to see you as well. So we have a couple of questions coming in. So let's see. One of them, oftentimes people want to prepare themselves for the potential side effects. They want to just know what's there. And that's part of what this program is for, is get out ahead of that so you know what to expect beforehand, so you don't have to worry about it later. So the question came in a couple times where people are just want to get a little bit more of a grasp on some of the biggest side effects that they can expect that are associated with Menopur, and maybe some of the different ways that you can either get ahead of those, or if you do have them, how to treat them after the fact.
Perfect. Those are all very good questions, and I'm glad you asked that. The biggest side effect is it may sting a little bit. Some people, they don't feel it at all, but it is an injection, so you may feel just a little bit of a sting or burning when you give the injection, but it goes away pretty much immediately if you do feel something. More than a side effect that you can experience is really the way the drug works. It causes your ovaries. It's the hormone that your brains would normally make that work right on your ovaries to develop and grow and mature your ovarian follicles, which contain the eggs. So when you're stimulating your ovaries with this medicine or some other medicines, it can cause your ovaries to get bigger, because the follicles that are growing the eggs get bigger. Oftentimes when you're undergoing this kind of treatment, the goal may be for in vitro fertilization. And if that's the case, the goal is going to be to get more than just 1 or 2 eggs. So when you take this medicine, you can have lots of eggs to develop. So depending on your dosage and your treatment plans, your provider is going to tell you a little bit about what kind of response he or she would want you to have. So if your ovaries are getting bigger, they may feel a little bit more uncomfortable. So those kind of feelings are being bloated, your genes don't snap together quite as easily, or just an increased awareness when you're walking around. It may feel like your ovaries are moving around a little bit, kind of like if you've on an empty stomach and you drink a big glass of water, it may feel like the water's kind of jiggling around in your belly. That's going to be the way your ovaries feel. On occasion, the ovaries get really big. And if that happens, then your ovaries can become painful. If that does happen, you should contact your healthcare provider, let them know. They are going to want to do everything they can to get the response that they desire, but also to keep you comfortable and to keep you safe and healthy. That's why you're going to have monitoring visits when you take this medicine. It's likely that your provider is going to want to do some fairly frequent ultrasounds and maybe some blood tests just to see how you're responding. So you hopefully won't over-respond. The dose of medicine can vary from patient to patient. A question that I commonly get is from patients in the waiting room saying, oh, why am I getting 150 units, but the lady next to me was getting 450 units? And if that's the case, it's because your treatment's different than what the other patient's is. Every patient is treated as an individual. So just because we expect you to respond on a certain dosage doesn't mean that's the dosage that everybody will respond to. So it depends on each person's unique history and treatment conditions and situations. So basically the side effects to Menopur are very low, but they're going to want to keep an eye on you as you're taking these medicines, just to try to curtail the risk of having great side effects.
Perfect. Thank you so much, Karen. I know that's a lot of times people, that the big benefit of the pharmacist program, like we mentioned before, is getting some of those jitters out of the way now so that you can be prepared when it comes. And that's really what we're here for, what we're trying to do working together, is allow you to ask those questions maybe you didn't get a chance to ask when you were last in the clinic or speaking to your nurse, or maybe it's something that popped up and you're getting ready to give that shot and you want to be prepared. So great question, great answer. And let's see, we have a couple other questions coming in right now. So there is one, and you touched on this a little bit when you talked about what Menopur is exactly, but this question comes in quite often, and I think it gets a little bit confusing for people who, you know, some people go on to FSH, some people go on to Menopur, and there's different ways you can do combo treatments and so forth. So the question is, what's the difference between using FSH alone versus Menopur? Why would you use one versus the other in a given fertility cycle? So if you could just maybe elaborate a little bit more on that for somebody who is looking just to get a good understanding of why they're on one medication versus another.
Absolutely. Great question. And that kind of points back to what I said earlier, is that every patient is unique and hopefully will be treated as such. Most of the time, I personally don't think it really matters if you're taking FSH or an HMG, which is Menopur. That's the only commercially available HMG in the United States. But I don't think that it really matters for most patients. However, if you are taking a drug like Lupron, that's going to slow down your hormone production, you may not make enough of that FSH, the FSH or the LH. So by giving just the FSH, it may not help you have a good response if you're missing the LH. Some other medicines that might impact it would be a little bit to a lesser extent the GnRH antagonists like ganirelix or Cetrotide. A lot of providers want to add in some LH as well. So it's nice if you're going to add in LH that it's already mixed in with FSH. So that's one less medicine you have to worry about. So to that extent, keep in mind that if you've been prescribed a combination protocol where you're taking both an FSH, such as Follistim or Gonal-F, and an HMG like Menopur, then every time you take 75 units of Menopur, you're also getting 75 units of one of the FSHs. The difference is that this is a urine-derived product, a human-derived product, as opposed to a manufactured in the lab product. So again, your healthcare provider is going to tell you what's best for you, and we never mind being asked why. So if you want to know exactly why you're being given medicine, ask about it. If you have particular questions, ask about it. I even tell my patients that they should make a list of their questions. When they pop into their head, just make it in a little notepad. And when they come back to see me next time, just ask those questions. Or if it's really a burning question, give us a call, talk with us or one of our other team members, and we'll be happy to make sure you're comfortable with it. Again, it's part of the end goal that we have in mind, how we want your response to be and what your underlying conditions are. One other time that it's important that women take a drug like Menopur that has FSH and LH is for people that have very low body fat. Usually it's because they're underweight or maybe they're marathon runners. They can have a lot lower levels of LH. So we want to supplement that. So there are a number of things that we take into account when we're deciding what the best medication treatment protocol is for you. Long answer to a short question, but I'm happy to keep them coming.
Perfect. That was great. Thank you so much, Karen. So this is a little bit more of a specific question here. But question comes in because you were discussing the way that you give the shot and obviously discussing the context of utilizing a subcutaneous injection. And a question comes in asking, is there a specific area of the thigh that you recommend more than others, whether it be for quality of the shot versus obviously reducing pain and so forth, reducing potential side effects. So just get a little bit more preparation when they're getting ready for that first shot.
Absolutely. Anywhere that you can pinch an inch is probably okay to give your injection because it's going just into fatty tissue. That being said, I think the best place to give the injection is your belly. It sounds kind of weird. I know my parents always told me not to pet that stray animal because it may bite me and give me rabies and I'd have to get shots in my belly for a month. And so that scared me or tried to scare me from petting stray animals or an animal I didn't know. But actually, they're there aren't quite so many nerve endings just in your belly, and that's a part of your body that's not as exposed to the sun and the elements as other parts of our bodies. And even really, really skinny people, if they lean back and then kind of push their abdomen forward, they're going to have a little bit of a place they can pinch and itch. So that's generally my preferred place. Two, if you have a little bruise after you give the injection, nobody's going to see it unless it's swimsuit season and you're braver than me and wear a little tiny bathing suit. If you want to give it in the back of your arm, I tell people just to lean the back of their arm up against a chair or a table, and then just go back in the very back fatty part of the arm where you can pinch an itch. Or if you want to do it in your thigh, which is also a reasonable place. I have a lot of people that prefer to do that before they've given an injection. That if you stand up and just kind of put your hand down to your side, right where your hand ends up on the outside part of your leg is where you can give it. So it's not quite straight down the middle of the front of your leg or not quite straight down the side, but it's a little bit between the front and the side, just to the side of the top of your leg, and then just pinch an itch and put the needle straight in all the way. It's very forgiving. The needle is tiny. It's going to be a 1/2 inch or 5/8 of an inch. So it's a little teeny tiny needle. And if you're pinched an inch, then it's going to have plenty of room to be able to give the injection.
Perfect. Thank you. I'm not going to lie, you actually scared me a little bit talking about the Rabi injections in your stomach for a month. So, oh man, this seems like nothing compared to that. So look at that. Anyone that was nervous, we just gave you, it could be way worse, right? So great. All right. Perfect. So the next question, speaking of things that could scare people, we always get this question for almost every single product, and it comes to the potential of, what if I make a mistake, right? You've answered this question a million times as well, and just as many times probably in your clinic as well. But the idea of people want to know, prepare again for the worst so that you can plan for the best, right? So the question is,
right.
What do I do if I make a mistake when I'm mixing my Menopur? So I guess we can take it as two different ways, separate. First, like just if you make a mistake mixing, how do you handle that before you give the injection? And let's say after the fact, you've already given the injection, you realize, oh no, I did something wrong. How do you handle that? Maybe we can give a 2-for-1 with this question.
Perfect. So this medicine, it's a little bit hard to make a mistake doing it, even though there are lots of steps. But a couple of the things that I've seen people do, one is they take one vial of the powder and mix it with a liquid, and then they take a second bottle if they're prescribed to and mix it with a liquid. Now they've got twice as much liquid as they really need. I think if you do that, if you use too much liquid, that's a lot of liquid to put into fat. You might need to give it in 2 injections. Another thing I've had people do is draw up the liquid and forget to mix in the powder. If that happens, if you've already given the medicine, if you already gave just the liquid, then you're going to have to take another shot that has the powder mixed in it. So a couple of things that can go wrong. If you take too little or too much for just one injection, it's going to be pretty forgiving. I really think the time that people get confused is when you're taking multiple medications. So if you are taking Lupron or one of the GnRH antagonists, Cetrotide or Ganirelix, if you're taking that and you're taking FSH, you're taking Menopur, you might be taking some supplements, it can be really intimidating and kind of scary. In those cases, I recommend that you do things like what I do and just set everything out all at once and say, okay, first I know I'm going to need this medication. Here are all the supplies. I'm only going to focus on this one. Do it first. And the same thing with each medicine that you're taking. If you take way too much, if you get a little overzealous and you mix up 6 powders and you're only supposed to take 2, we wouldn't want you to take that. But then again, if you've already taken it, you should probably notify your healthcare provider, say, look, I think I took too much of this one. Since this one has to be mixed, it's pretty easy to take the exact dose to make sure that you're doing it right. It's it's a lot of extra mixing to take 6 over 2. So I think that's very unlikely to happen. I think probably the most common thing that I see is people using too much liquid. It's not going to hurt you to take that much liquid. It may sting a little bit more. So I like for patients to keep it around a cc, maybe a cc and a half at the most, to give it subcutaneously.
That's great. I think anytime we can let people know if you make a mistake, it might sting a little bit more, then you have a vested interest in making sure that you don't accidentally make that mistake, because it'll get you. So that's great. Thank you so much. That's a perfect answer. And I think that's the kind of thing that we are really trying to drive home with the pharmacist program, is those types of questions you can ask now, get out all the jitters, get out all the, all the little potential things that you're worried about that you might make a mistake, so that when that day comes to pull that first needle out and give yourself that injection, you've already gotten all the mistakes out of your way in your head, so that you don't make them into your body. So great. So thank you so much.
Sure.
Looks like we're all good right now with questions on Menopur. So one thing, as always, what we like to do is I'll give people another like 30 seconds or so. If you have a question or that answer sparked a question in your head that you're trying to furiously type into your keyboard or on your phone, as we get ready to move on to the next product. So in the meantime, I'll throw it back over to you, Karen, and anything else you want to share before we check for those questions, and then move on to the second product tonight.
Perfect. Thank you. So as I said, the first injection is always the hardest because it's a little bit unfamiliar. Most providers have like a little practice kit in their office and will demonstrate exactly how to do it. There are lots of resources available for you, including the pharmacist program. You can go on mymandells.com and find the links to not just me showing how to do it, but several different providers showing how to do this injection. And maybe you'll pick up a tip from one of us that you didn't from me. So it's worthwhile just to look at that. There are lots of YouTube videos, but keep in mind, anybody can post anything on YouTube. So I think tuning into a pharmacist program or looking back in the archives at mymandellspharmacy.com is your best bet to make sure you're getting information directly from a healthcare provider. And always ask your provider if you're still uncomfortable. Just let them know. I've had lots of patients come in and say, can I just come in and you watch me do my very first dosage? And of course you can. We're happy to do that. Everybody has your best interest at heart, from people like myself who are watching from afar, to the pharmacy, to your doctors, your nurses, the embryologists, the whole healthcare team wants you to succeed. And the only people that want you to be pregnant as much as you yourself do are probably the people that are on your team. So we want to make it easy for you, and we want to have information accessible and readily available for you. You can also just pick up the phone and call them at Mandell's and tell them that you're just a little bit nervous about how to do it, and they can answer any of your questions as well. They've got a phenomenal team to help you out. So Craig, did we get any other questions?
Looks like we are all good. We're caught up on questions. We'd like to remind everyone at this time that no problem. If you think of a question later on, you want to go back to Menopur, you have a question, even though we've moved on, we can answer questions about any of the products. And we will also have time at the end to ask any questions about anything at all that might be on your mind, whether it's 3 products, general fertility questions or infertility questions, and any of that you can bring up. So have no fear, you'll have plenty of time to ask your questions, but at this time we are ready to move on to the second product tonight.
Now we will review how to use a Centerra patch. The patches will likely come in packages such as this. So I recommend just gathering your supply there and deciding what site you want to use. Now, the patch does need to be applied directly to the site that you plan on doing an injection, and it does need to be applied about 20 to 30 minutes prior to your planned injection. You'll take your patch out of the packaging. This is the top of the patch, so when it's on, this will face outside, and then the sticky part is here, and there is a plastic film over it that you'll need to peel off. So it comes apart like this. And this does need to be applied to skin that is unopened and clean. So if you have residual tenderness or scabs, I wouldn't recommend putting this over that skin. I would find a fresh new site. And then after that, you just apply the patch to the skin. Make sure it's flush against the skin. You do want to make sure to not cover up this outside part where it has these little vented holes. That's how the patch begins to do its magic. So when it's on, it'll actually feel kind of warm, and that means it's just increasing that blood flow in order to kind of absorb the medication even quicker. Once you have it on for 20 to 30 minutes, you can peel the patch off. And then prep the site for your injection. And that's how you use the Centerra patch.
Okay, awesome. Okay, looks like the first question we have, does a Synera patch need to heat up? Or if it does, why does it need to heat up?
Yes, so the ingredients cause kind of that heating mechanism to occur. That's how, number one, you know it's working, and two, it also kind of helps blood flow to the area. So it helps to increase the effects of that medication as well. So as long as you feel that patch heating up on the skin, you know it's working, it's doing its job, so don't be alarmed there. Also, you want to make sure that you are leaving the patch open to air. So there's actually, I have one here. I don't know if you'll be able to see on the video, but there's little holes on the outside there. That's how it intakes the air. So when you have the patch on, you want to make sure it's not up against any like tight clothing or anything that would cause, a covering over that would keep air from coming in. Otherwise, it won't be able to heat appropriately and kind of activate, if you will. Very good question.
And do you know about how long that the area will stay numb for after applying the patch?
I'm not 100% sure on this one. I want to say maybe an hour. Morgan, do you have any insight on this one?
Yeah, I think they say about it has effectiveness for about 30 minutes, but you shouldn't feel after like an hour. But I've had patients say only 10 minutes, and then some tell me like 2 hours. But nothing really longer than typically 30 minutes from what my patients tell me.
Perfect. Yeah. I mean, I know that, it's kind of a one patch per injection deal. So if you do it for a morning injection, you have an evening injection, you're not going to be numb for that. So, it's one patch per injection. Get rid of your patch. You need a fresh one every time.
That's huge. Patients I've asked if they can reuse them. And I'm like, nope, you're not going to have the same effect with them.
No, you won't be as happy.
Agreed. And then what if, Synera, if it's like in your car, if it gets exposed to like heat, do you think that they'll still work as effective, or they should throw away and get a new one?
You can certainly try it. I don't think it's going to hurt to try, but it may not work as well. So if you find that, it may have already kind of activated those ingredients in there. So you can certainly try it. But if you find that it didn't work as well, or if your skin isn't as numb, just, kind of touching it with your fingernail, you could always put another one on, a fresh one that wasn't affected.
Perfect. And then with the Synera patch, can you use it for sub-Q and intramuscular injections?
Yeah, absolutely. I have patients that use it for both. I have some that just kind of opt to do it for intramuscular injections, and that over time they've become a little more comfortable with the subcutaneous. But yes, you can definitely use it for both types of injections. Just make sure eventually in your cycle, when you're doing your trigger injections, that you're timing that out very specifically. You have to make sure you're giving yourself that 20 to 30 minutes with the patch beforehand. So your trigger shots are the ones that are super time sensitive. So you really want to be on top of those ones. But yes, to answer the question, you can use it for both routes.
Perfect. And it looks like we got a question. Is the purpose to just make the injection site more comfortable when administering the injections?
Yeah, that's exactly right. So the goal is that you won't feel it as much, if at all. I also would say that some of my patients tell me that with their progesterone and oil injections that they use in a transfer cycle, the heating mechanism kind of helps to disperse the oil a little bit. So there might be some added benefit there as well.
Perfect. And I think that is all that I see questions coming in with the Synera patch. I can say my patients love these patches, especially with the intramuscular injections like the PIO injections, progesterone oil injections, or their triggers. I think those injections can be a little scarier to use. So patients definitely are more hesitant, and with them, you really don't feel a thing. I actually tried it out one time. I think they're awesome. They really do numb the site really well.
Yeah, I 100% agree. Although they're technically optional, it certainly does not hurt to give it a try, So definitely something I would ask your providers about and see their take on it. But I can say that I don't think I've ever had a patient that says they wish they didn't try it. So.
Hi everyone, the following video is here to show you the mixing and administration instructions for HCG. HCG stands for human chorionic gonadotropin. Sometimes your pharmacy may have sent you a box that has the name on it Pregnil or Novarel, or it might say chorionic gonadotropin. Any one of those three varieties is your HCG injection. And typically this is administered to induce an ovulation. Sometimes it's called the trigger shot by your nurse or by your clinic. When you're taking this, it's to, like I said, initiate an ovulation, and you might be preparing for a procedure to follow, such as an intrauterine insemination or an IVF egg retrieval. Your clinic will review specific mixing instructions for this medication, and they will review your dosage and the method of administration. For the video today, we will demonstrate that this medication can be given either as a subcutaneous injection or it can be given as an intramuscular. If we use intramuscular, we'll demonstrate that we use the buttock muscle for that. And with the subcutaneous, I will show you that it goes in either the lower belly or upper thigh area. Some supplies that you're going to need to get started with this medication, just to give you a little list here, is going to be your box that'll have HCG on there, or Novarel Pregnil. You'll have 1 vial of HCG powder or tablet. So sometimes our lingo is, some nurses will call it a powder or a tablet. Either way, that's the same. You'll have 1 vial of sterile bacteriostatic water. You'll need a 3 milliliter syringe, one of those. And you will need 2 22 gauge 1.5 inch needles if you're doing intramuscular injection. If you're doing subcutaneous, you will be using 1 22 gauge 1.5 inch to mix the product, and then to inject it, you will be using a smaller needle that I'll demonstrate, but is a 27 or 30 gauge 1/2 inch needle, which is a tinier, shorter needle to go just into the fatty tissue. So it's always good to get your supplies together first. Then you can always wash your hands before you're getting ready to do this. Administering an injection is not a sterile technique, but it's always good to have clean hands when you're mixing the product. So what we'll first do is, from our box, we will remove the 2 vials that we will have. One of those vials will have the powder in it. We'll simulate that with this one. There'll be a little plastic cap on the top that you remove. And the other vial will have sterile water, which you can see sort of here that we have some water in this one. And you take the cap off, the little plastic cap off that as well. Another good idea to do is that you will use a alcohol prep pad if you have it, or a cotton ball with alcohol, and you'll just wipe the tops here with alcohol. It's just a good idea whenever you're poking a needle into a surface, whether it be skin or vial, to just clean the top of that as well with your alcohol. Your syringe that you'll have, the 3 milliliter syringe, may have the 22 1.5 inch needle already attached, or then that needle might come separately. Either way, we would put that needle onto the syringe to get started. So we'll need the 3 ml 3 cc syringe with this 22 gauge 1.5 inch needle for injecting. And what we will first be doing is, I'm going to demonstrate a basic mixing method with this, but your clinic will review how much liquid to mix with, and they'll give you specifics. But even seeing my way of mixing is going to give you what you need to know in terms of the mixing. So for the demonstration, what we'll do is we'll mix with 1 ml 1 cc. So what we do is we draw down the plunger and we draw up a little air, and then we uncap the needle, and we first take our vial of sterile water, And we're going to inject a little air into that because there's a little pressure in that vial. So it's nice to kind of equalize that little bit of that pressure in there with entering a little bit of air into it first. If you forget this step, I don't want you to worry, but I just want you to know it's something that we can do, because as I let go of that plunger, it sort of has a little mind of its own and it's moving. But then what happens is eventually that'll all stop and I will be able to have full control over what I'm drawing up. So in this case, we're going to draw down that plunger rim to the number 1 ml, 1 cc. Once we remove that needle, this is extra fluid that you do not need to keep around, and you can put it safely into regular trash because there's been no blood contact with it, so you don't have to put it in your sharps container. Then we're going to take the sterile fluid that we've drawn up and insert it into the powder, tablet, wafer, however you want to refer to that powdered vial, and inject all that fluid in there. At first it'll be cloudy, but then just keep that needle in there, and what you're going to do with that needle while it's in there is just roll around gently. It takes a few minutes to do this step, but just let it take, don't rush it. You just don't want to shake vigorously and create a lot of bubbles with it. If you can, you want to kind of minimize all that bubbling effect. Once you see that it looks pretty clear in there, the next step is to turn the vial, or some people say invert the vial upside down. The next little cue that I always give to everybody is make sure to move that needle down as low as you can without having it fall out, because then what you're going to do is pull back on the plunger and drain every little drop that you've pushed into that vial. So 1 ml went in, 1 ml is what should come out. If you're slightly under it, is that okay? Absolutely. But if you're at a half, go back in, because that means you'll have the other half still left in the vial. So what went into that vial, the 1 ml, as close to that is what you want to remove from that vial, that 1 ml. Then this vial here will, once again, this is also going to now be empty because we've drained everything. So this can go into regular trash. You don't have to put it into a biohazard container. And then you cap the needle that you've been working with for mixing. Here's where there'll be two differences, and I'll show the intramuscular shot first. After we have our ready mixed vial here, syringe, we're going to remove this 22 gauge 1.5 inch needle and discard, and we could open a new package with a 22 gauge 1.5 inch needle that we'll borrow from that new package. In this case, we would simply not use the syringe that came with it, but take the brand fresh new needle that's nice and sterile, because that's going to mean that's going to be good for your injection. This would be the needle that is used for a buttock muscle injection. If I were doing a subcutaneous injection on the advice of my clinic, which they will let you know, and that would be something going into the belly or the upper thigh, then you would be using a much smaller needle. So the only step that would be different is, I'm just going to take this off for a second and set it down. The only step that would be different is after mixing, I would then attach the very small needle to get ready for preparation of the injection. So we'll put that one back into that packet, and I'll come back to that. But I just wanted you to see that the mixing needle is a longer needle, so it goes in those vials, and then you may be switching to a new needle that's longer for a muscle shot, or a smaller needle that might be for that subcutaneous injection. And I'll just move everything away here. And what we're going to do is, this is an injection if we're showing and demonstrating the muscle shot first. Typically, your nurses in clinic may have drawn some circles on the upper outer quadrant of the buttocks, just to show this side here. It's just to show you that the needle's going into that red area. So we're kind of not doing a subcutaneous, which is the fatty tissue, but we're doing into that muscle, that's that glute muscle, and that's a nice big muscle for that. So a lot of times some people have asked if they can do this in the leg. It's usually preferred to give it here because this is a non-weight bearing muscle. So we sort of would avoid sometimes doing the quadricep or the deltoid of the arm, because that's a small muscle. So often you'll see that your clinic centers may be circling this area for you to administer this trigger shot. If somebody, it's recommended with this one, if somebody can, to be administering this to you. And if you were to choose to stand for the injection, what I would do is, if I was getting the injection in my right glute, I would stand with all my weight on the left side, and I could lean a little bit just so that I'm not wobbling. I could put down my right foot, and that person would have a nice relaxed muscle to administer that injection into my right glute. However, if you would like, you could lay down simply And if I have this mannequin and she were laying down here and I was administering the injection, then by having her lay on her side and I'm administering the shot right here, the muscle's already relaxed. So either way is fine. There is no right or wrong way of standing or lying down. It's just whatever works for you, and that's what we would always want you to do, is whatever works for you. Some people ask if they can put a little ice to the area. For this injection, a lot of the clinics might say it's okay to put a little ice to numb the surface, because you are going a little deeper and that will not interfere with absorption. Or your clinic may be working with you and may have ordered you some Synera patches, which is a type of numbing patch that you would apply about 20 to 30 minutes before this injection and then remove it to then administer the injection. So if you don't have the patch, it's certainly okay to sometimes, with your clinics, okay, use a little ice just to numb it. If you didn't ice, what I will say is that a lot of times by now you've had several blood draws from your arm. The pinch that you could feel a little bit here is just like a blood draw, even a lot less, because it's not going into a vein, it's just going into your muscle. So I want to give you confidence to know that not to worry about the needle going in, because you've experienced that already with those blood draws. With this, after you do the icing, or if you use a patch, what you're going to do is clean the area with a little alcohol, and then you're not going to pinch the skin. We need to leave it just as is, because we want to get that needle right into the muscle. So the angle that you might see me holding this might look like a slight 45-degree angle to you, and your other hand could be here, wherever you position it that's comfortable for the person giving it. But a slight little angle, so I'm not pointing the needle down toward the floor, and I'm not parallel to the floor. It's a nice little angle so that it's going into the muscle. We don't need to jab with this. If you do see that you have a little bubble in here, or a little air bubble, is that something you want to address? You can give a little flick to the syringe. It usually rises that bubble up to the top. But if it's a real tiny one, I don't want you to worry either, because you're not using this into a vein, and that's when we really want to look for air bubbles. For a muscle shot, it's okay if you had a very small bubble there that just can't be moved, and I can even have that happen to me as well. So it's okay to flick at that to release it, but if it doesn't release, it's certainly okay to proceed with your injection. When you're doing this, like I said, it's a nice gentle angle in and a nice insertion. We do not need to jab. So you place the needle to the skin and then give a little gentle push. If you've iced or used Synera, you might not feel anything at that point. If you didn't ice or Synera, you might feel just a slight pinch to that skin, sort of like a blood draw when that needle goes in. The next step is to hold this needle in place and pull back lightly, gently, not a lot, not very far, on the plunger. Why we're doing that is we're just checking to see if any blood enters the syringe. If you've had these areas drawn, it's very unlikely that you will enter a little vessel or a little vein. That's the reason for this check. So I want to reassure you that it's not very common to happen, but when you pull back, if you were to see blood enter here, clinics might do different things, so you follow their instruction, but what we would do is either remove the needle completely if we see a little blood enter, put a little Band-Aid here, change the needle, and go to the other side to reattempt. Or the other way you could handle it is if you see a little blood, you could pull the needle away from the skin, approximately ½ an inch, check again, and if no further bleeding enters, then you could just inject. Either way is how you'll be instructed with your nurse's help in your clinic, but that's just addressing that if you do see blood, you don't want to insert the medication. You want to hold off and reposition, or remove it and go to the other side and reattempt. Either way, eventually you will get to the point where you're not going to see any blood, and you probably won't even see it the first time, and then you'll just inject nicely that fluid, let it all go in. Can do a little count of 1, 2, 3. Remove the angle, remove the needle at the same angle as going in, set it down, and then you just put a little cotton ball there. A little bit of blood will come out, a little bit of the fluid, not a lot. It'll only take 10 seconds of holding this here, not even. And then you might have it where it will stop and it'll have a little pinprick there. And you can apply a Band-Aid if you need to. Just remember you have that there. Don't forget, because it's in the back of your body. Just because Band-Aids, even if you don't have an allergy, sometimes can get a little, you might get a little irritated from that. So you just want to be able to know you don't have to leave a Band-Aid on for 24 hours or anything like that. Just for the quick 10 or 15 minutes, and then you can remove it. If this injection is being instructed by your clinic to take it as a subcutaneous injection, then what you want to know with that is the areas typically that they will reference for you is going to be in the lower abdomen and the top upper or side outer thigh area. because it wants to be in any area that where you can pinch a little fat. So using my arm for that, I'm pinching a little bit of fatty tissue off of the muscle. And when you do that pinching, just do a little gentle lift. You don't have to squeeze too hard so that you're not traumatizing your skin by squeezing so hard. You could, with that little shot, subcutaneous injection, you could administer that to yourself, or you could have someone administer that to you. So that's an option. The intramuscular, it's usually recommended if you have someone that can give you that shot, it would be preferred. But with this injection, if you felt comfortable, you could self-administer, or you could have somebody give you the injection. If somebody were to have someone else give them this injection, I usually sometimes recommend that the patient could lay down and you would administer it into her belly this way, because it's a 90-degree angle, or you could administer it into the top thigh this way. Or if we're doing the side thigh, then the 90-degree angle to the side thigh is administering it like this. So it's a 90-degree angle, and if you're getting the shot given to you, then you could lay down. If you are administering the shot to yourself, then you would be in a position of where you could stand or sit, and you would be giving this straight into your belly, straight into the top thigh, and bring it into the side thigh to the side area, like we showed earlier, a little bit of that side thigh. So again, the angle for this one is a straight in, but it's a smaller needle just going ½ an inch into the fatty tissue. So if we demonstrate that one, if somebody were self-injecting, question might get asked, can I put a little ice here? You could, but it's sometimes it's recommended if you're going to do anything here, maybe to use one of the numbing patches if you have that option, that's ordered for you. But even if you don't have the numbing patch ordered, recommendation is you don't really have to ice these. It's such a tiny needle, you may not even barely feel it. At most, it might feel like a mosquito bite. We all know how that feels. It's a very quick, fleeting pinch. The reason sometimes we recommend refraining from icing with the smaller shots is that you don't want to constrict blood flow. Blood flow needs to be open in the little capillaries to help that medicine be delivered to where it needs to go. So the idea here is just we don't want to interfere with that. The numbing patch won't interfere with that, but the ice, if you leave it on too long, could. So it's best to just know that you really don't need the the ice for this. And oftentimes patients, when I do demonstrate this, they will let me know afterwards that it really wasn't as bad, and I was right, that it felt like a pinch or nothing at all. So I want to reassure you all of the same thing, that it really is something that you won't notice very much when the needle goes in, because it's so fine, that needle. This time we do need to give a little pinch to the fatty tissue. So what you want to know with that is you're giving a gentle little squeeze to the skin, like I said, not a harsh squeeze. You uncap your needle, and then when you have that little pinch of fat, you place the needle right to the skin and just give a gentle little push. Once it's all the way in, you can then push the medication in, nice and gentle. Count 1, 2, 3. Remove the needle, same angle as going in, let it out, and then put a little pressure there. Here, if you'd like to Band-Aid, you usually don't though. If anything, you might see a little clear fluid come out of this opening. So that's the medicine, so we want to make sure we put a little pressure and keep it there, keep it inside the body, but usually not needing to have to do anything with any sort of Band-Aids or anything like that. And then with all of your medications, after you are done with them, when you have this dirty needle and syringe, it goes into that sharps container. So there is no leftover with trigger HCG. Everything you typically mix is going to then be utilized for that evening, that day, or that evening, or that morning, whatever time you're taking this. Your clinic will give you specifics with when you're taking it, how much water you're mixing with. Today's demo was to just show you the demo of mixing, and we use 1 ml 1 cc, but you might use more, you might use less, or you will absolutely be instructed whether you're taking it as a belly shot or thigh shot, little tiny injection, or whether it will be in the muscle. So I do hope this video has helped you. If you've gotten to this point, I know you have good things ahead, and we congratulate you on getting to this point of a trigger shot. And best of luck to you with the rest of your cycle. And we'll see you back here for some future videos. So hopefully that was helpful. I think the trigger shot tends to be a very big shot in most of our clinics, and patients have heard a lot about it. So they certainly get concerns or worries, lots of questions around this. So there's a lot of patient education going on in most clinics like Tony's and mine, where we're always doing all that we can to make sure that patients are properly instructed for them on their dosage, their method of administration with this medication. So this one gets a lot of attention, and I'm sure Tony would agree with me. And I don't know if there's further questions that anyone has out there about it.
Oh yes, this is the big one for sure. I actually liked in the video that you commented after the IM injection, which typically we do ours IM in our clinic for IVF. A lot of our intrauterine inseminations are sub-Q, so we do teach it both ways depending on the cycle type. But the fluid coming out at the end, sometimes with the IM, tends to make people nervous that they did something wrong. So it is okay, just to wipe that little bit off, and you still did get majority of the dose. So we try to, set their mind at ease for that.
Exactly.
Just a few questions so far. How do I know exactly what time to take my trigger shot?
This is something that, as I said, there's a lot of teaching that goes on with this. I know at most clinics like our own, when you are doing this for a cycle that might be for intrauterine insemination, oftentimes you may be given a range of time that you can take it. Just for example, you might be told anywhere between 7 in the evening to 9 in the evening. So you may be given a range depending upon the procedure. With IVF, usually you're given a very specific time, because oftentimes most clinics are doing one retrieval at one time, meaning each person has their own scheduled time for a retrieval, and how you have that scheduled time is based on your trigger shot time. So just know that, that is an important key factor with IVF cycles, is that this is the one medication, and pretty much the only medication I would say that's in our clinic at least, and most often everybody else as well, that is a timed injection. And that means that the time that's given is very important to follow that because of the setting up of the operating room and the schedule with what you're doing when you're under anesthesia for a retrieval. At least that's where we're at with our clinic in terms of doing that.
Yes, absolutely. This is another good question. Can I mix my trigger shot ahead of time, and do I have to be at home to administer it?
I have had some people probably be at restaurants out doing the same thing, right? You should know hopefully by the day's end at a clinic what time you're taking your injection. So usually most of us might have a 9 to 5 day or an 8:30 to 4:30 day. So you might be hearing from the clinic for sure by the end of that time frame during the day. So you'll be able to prepare for that evening. And if you do have plans being somewhere, I guess if you're somewhere that you can at least get the injection, then sometimes we do tell patients if you're traveling to a different location and you're going to be available to do the shot at that location, bring the medication with you. What was the other question? I think it was time. I forget now. We said if we're a different location, or I can't remember the first part of that.
Oh, do I have to be at home, and can I mix it ahead of time?
Yeah. In terms of like mixing ahead of time, again, being that it's powder water, it's activated upon mixing. So usually most clinics will recommend mixing it no sooner than 20 minutes or so, give or take 15 minutes, and then be prepared to do that. I know for us even, there are times when patients have a very late injection. It might even be when they're normally in bed. And you know what we always tell patients, take your phone, set a timer. If your time of your shot is midnight, then make sure to set your timer at about 11:30 so you can gather your supplies and start your mixing at about 11:45. Because I know for me, I'm up at 4:30 a.m. So that would be a very late evening to be up that late. So, we often will remind you, because it's not unusual that somebody could be tired and they may fall asleep early, and we want them to know to be able to do little tricks of the trade, if you will, and making sure you get that shot at the time you're told to take it.
Yes, absolutely. The timers become your best friend when you're doing your IVF meds. You definitely don't want to miss the trigger shot time.
Exactly.
And then if you do, all you can do is just let your clinic know, and they'll direct you from there as to if it's something that can be moved, or, they'll go through the next steps from there.
Exactly.
Another question we have, which is a good one, we get this kind of stuff a lot too. I was prescribed Pregnel, but my friend was prescribed Avidril. Is there a difference between them?
Most often with regards to the trigger or the HCGs or the Avidrils, first off, to be quite frank, one of the things we want to always work with is which products might be considered in are in your insurance formulary, meaning that there are certain products that you might have coverage for and other products that may not be covered for you and you'd pay more out of pocket. We're never going to compromise your cycle in that choice. But to be honest with you, when it comes to the HCGs and the triggers and the different names, there are times that you could use interchangeably one or the other. Ovidrel is a little different than the HCGs that you saw that I mixed, because Ovidrel, it's a subcutaneous, but it's a pre-filled syringe ready to inject. So sometimes there just might be dosage variations, but if you're covered for one, like the Ovidrel, there's a way for us to make sure that you get the full dosage. And there are some clinics that might be having their patients use one or two of those pre-filled injections to give them the full benefit of the drug, even though it's a different named product and the way it looks. And then the HCGs might have a 1 bottle, 1 box that is a higher dose that equals 2 of the Ovidrel. So there's a lot of little different variations out there, guys. I wouldn't get so hung up on that. I would want you to know that every clinic is going to always do what they can to try to make sure that you're getting what is hopefully the best product for you in terms of response with dosage, not so much the drug's name and presentation, and really their coverage. Working with those insurance coverage is very much key to all of us.
Yes, absolutely. So I don't see any more questions before we wrap up. I know you wanted to add something kind of at the end, so
Yeah.
if you want to take over there, and if something else comes through, we can address that.
Sure. Okie dokie. So I was telling Tony, I'm a certified healing touch practitioner. It works with energy medicine. And what I find with fertility is patients often ask about the stress. Is stress going to cause me to be having difficulty getting pregnant? It's not just stress. We all have stressors in our lives. We're always going to have stress of some sort, of some level. I think it's how we respond to it that is the most critical key factor in that. So I don't say necessarily that stress can't be a factor, but it's your response to it. So in giving you some little tips, our hands have energy centers here, and I've showed this before on some previous live events. And I have a little trick of something that can help be calming to stress levels and stopping unwanted negative thoughts. It's called the forward back head hold. So you would take one hand and place it on your forehead, and then on the back of the head where you have that little bumpy ridge there, that's the occipital ridge, you would kind of gently hold. You don't want to put hard, heavy-handed pressure, but a gentle little hold. If you can be quiet in a room by yourself, sitting up, laying down, however you want to position yourself for this. Calming music is nice. Being able to just take some nice breaths. This can be a really great technique, because when we are in fight, flight, or freeze, the blood flow leaves our forebrain and it goes to our extremities. So that when we're in flight, we need our extremities to have the energy to run, or we might freeze and stay still, or we might fight. So the idea here is that because you have nice energy in those hands, of the center of those hands, and we all have it, by placing our hands one behind and one ahead, so we have that forward back head hug, I like to call it. It's a nice little hug. What it does is it puts blood flow back into those areas. If we don't move that energy from the trigger out of our body, what can happen is it can stay stuck, and it can cause our, disharmony within our body. It can make us feel anxious. So this is a nice calming hold to bring blood and oxygen back to the brain, helping us to find peace and clarity. The other nice thing to add to this is I'm a believer of affirmations, and I've shared this in the past too. A nice affirmation for our fertility patients is, I love and approve of myself. Because how many times do we do a lot of not so nice talk about ourselves, like, why do I have to do this? My body's not helping me. I don't want to have to do this. Your body's listening to that. Thoughts are very powerful. Affirmations are statements that describe a goal in its already completed state. So by you saying, I love and approve of myself, even if there's a little part of self-doubt in that, by just saying that, your body hears that, and it reinforces as you bring more energy into any thought or action, it'll increase the powers of creation of that affirmation. So a little forehead, back head hold, a nice calming couple breaths, and I love and approve of myself. And even just saying that a couple times before you start the cycle, during your cycle, anytime you need to do this, even for our nurses out there, we all can use that tip.
Hi everyone, my name is Laurel Meyer, and today I'm going to show you how to draw up and give your Delestrogen. This medication is made by different manufacturers, and you can see by this slide that the vial can look differently depending on who makes it. It does come in 3 strengths, 10, 20, and 40 milligrams per ml. And the reason why I mention this is it's really important to check your vial and see what strength you have, and then let your clinic know what strength it is, and they can tell you how much to take. As an example, a typical dose is 4.8 milligrams twice a week intramuscularly. So if your strength is 10 milligrams per ml, you would give 0.48 milliliters. As the dosage, or as the medication gets stronger, you give less. So with 20 milligrams, it'd be 0.24, and with 40 milligrams, it would be 0.12. And I'll show you how to find that on the syringe. So the main thing is just to make sure you check with your clinic, tell them what strength you have, and they'll tell you what dose to take and how often. Now, Delestrogen is used to thicken the lining. It's typically used in a frozen embryo transfer cycle, and it thickens the lining so that it becomes a nice home for the embryo. We're going to talk about now where to give that shot. And there's 2 IM injection sites. There's one called the dorsogluteal muscle. This is the upper outer quadrant of the buttocks. If you put an X on your buttock cheek, it is the upper outer section. This site, you do need to aspirate, and we'll talk about what that is in a few minutes. The other site, the ventrogluteal muscle, is on the side of the body. And to find this site, I want everyone watching to find your hip bone, slide your fingers about 2 inches below the hip bone, right on the side of your body. And this is the ventrogluteal muscle. Slide your fingers 2 to 3 inches straight back from that site. This is the dorsogluteal muscle. Now, if your partner is finding the site for you, they can do as the picture is showing, find your hip bone, put their fingers under the hip bone, and spread the pointer and middle fingers apart to form a V, and this is the site. So this is the ideal site for several reasons. The ventrogluteal muscle is much bigger than the dorsoglute. It does not have any nerves or vessels that are large enough to puncture or to damage in any way. So this is considered the perfect site for an IM shot. It also can handle that shot that's given repeatedly for over several weeks, like the Delestrogen is. So the next thing we're going to do is to draw up the medication. We are going to gather our supplies. You're going to need your medication, your 2 needles, one for drawing up and one for giving. And you'll want to look at them, and you'll want to see there's one that's thicker that you're going to draw up with, and one that's thinner that you're going to want to give it with. There's your 1 milliliter syringe and your alcohol wipe and a Kleenex. Okay, you want to have all these supplies ready. You want to wash your hands first, of course. First thing you'll do is take your cap off, alcohol the top of your medication. You want to do this every time. And then you get out your syringe and your 2 needles. You'll put the skinny one just on the table, and you'll get your thicker one and you'll put it on the syringe. So twist it on like that, and you're ready to draw up. Now, I'm going to use 0.24 as an example because this is typical. 0.24 is, if you look at your syringe, you find the 0.2 line, and you count 4 little lines past it, and you put that amount of air in if that is your dose. So whatever your dose is, that's the amount of air you're going to put in your syringe. take off your cap, put the needle in the circle in the very middle, and turn everything upside down. You're going to pull back a little, making sure that the tip of the needle is in the oil. Push your air in, and then draw back, and it will start to drip slowly down the side. And this is one of those times that you have to be patient because it will drip pretty darn slow. And as you can see, it's just drip, 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 sliding down the side. And you want a little more than your dose, and then you can push the air out. And you want the black line to end up right at your dose. So I'm going to go to the 0.2 plus 4 little lines, like that. Now you turn everything back up, right side up, pull your needle out, and then with a one-handed technique, you want to recap. The best way to do that is just to put the cap on the counter and slide the needle in like that and click it on. Now you switch to the give needle. And now you're ready to give the shot. So a couple helpful hints on how to make this shot less painful. You can choose to purchase a numbing cream or a numbing patch. Synera is a numbing patch you can use. And if you use either of these, you won't feel the poke at all. You can choose to ice the site for about 60 seconds beforehand. That can help. And another nifty technique is the tickle technique. That's what I call it. So what this is tickling the skin next to where you're going to give the shot on either side as you're going in with the needle. And this takes advantage of what's called the gate nerve theory. And it will actually trick the skin into not feeling the poke. And it works very, very well. So what you're going to do is pick your site, and you want the muscle to be completely relaxed. So in order to do this, I would recommend just lying on your side on a bed with your partner next to you. That's going to give you your shot. Or if you prefer to stand, you can stand with all of your weight on the opposite leg from the side you're going to receive the shot. So I would have a counter handy just for balance and put your toe on the ground for stability. And your partner can sit in a chair next to you. Or if you have to give the shot yourself, I recommend the same standing technique. Put all your weight on the opposite side from the side you're going to give it. And I would give it on the dominant side with your dominant hand. So if you're right-handed, it'd be the right hip. So with that in mind, now to give the shot, the tickle technique, tickle, 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 and you're going to go straight in like a dart at a 90-degree angle. If you've used the dorsogluteal or the upper outer quadrant of the buttocks site, then you'll need to aspirate. And what that is pulling back on the plunger and looking for blood return. The reason you do this, although it is very rare, sometimes the tip of the needle can go directly into a vessel. And if the tip is in the vessel, you're going to pull back and see blood that comes into the syringe. If that happens, you're going to want to pull this out, switch the needle to a new needle, and go to a new site and give the shot. And it's okay to give the blood, the medication with the blood mixed in back to you because it's your blood and it won't hurt you. But if you use the ventral gluteal site, you can skip that step. So you go in, you just go ahead and give the medication. Once it's all the way in, wait about 3 seconds, pull out, and have a Kleenex handy to hold the site firmly. You want to keep your muscle relaxed this whole time. And then after about a minute, your partner's going to check the site. If there's any blood or medicine leaking out, you'll continue to hold the site until it's dry. Check it again, it's dry, you're all done. Everything will go in the sharps container. And then this will go back in the cupboard. You don't want to put this in the refrigerator, and that's all there is to it. All right, Morgan, any questions coming on Delestrogen?
Yeah, first of all, the tickle technique. I've actually never heard of that. I've been doing this for like 10 years. So I'm going to take that back to my clinic as well. One thing is someone wrote in and said that they're on Delestrogen, but their friends aren't. A lot of their friends they've gone through fertility or not. So why do you think that they may be on it? What is the purpose of Delestrogen, and what is it kind of doing to help with their cycle?
Okay, good question. I know that people get concerned when, people they know are on different protocols than they are. And I wouldn't worry about this. There are a lot of different reasons. The primary reason I think is that different providers have different preferences. They've had success with particular protocols. They like them. They're doing well with them. Their patients do well with them, and they like to stick with them. That's one reason. Another reason that you might find that Delestrogen is one way of giving estrogen. It's intramuscular. It's typically given twice a week. There is estrogen tablets that you take orally. There's vaginal estrogen. There's estrogen patches that you can put on your buttocks or your abdomen. So there's so many different ways of getting estrogen into your body to build the endometrial lining. The Delestrogen sometimes is given when your uterus is a little bit resistant. You've shown that it doesn't build up as thick as adequate, as good as it could be. And so this is a little extra boost of estrogen that you might need to get a thicker lining. So just know that your provider is picking a protocol that they think is going to work for you. And just also know that this is not an exact science. There's no right or wrong. It is something that each provider just does what they feel comfortable with, and given your history, will pick what's right for you.
Beautiful. And then typically, how long should patients expect to be on this medication? Very typically speaking, of course.
So typically your provider will tell you to stay on this until 12 weeks of pregnancy. At that point, the placenta has taken over in creating enough estrogen and progesterone to maintain the pregnancy so that your body can do it on its own. But it does take approximately 12 till about 12 weeks of pregnancy. This is typically about 9.5 weeks after your actual frozen embryo transfer.
Perfect. And since patients are going to be on this medication or potentially on this medication for such a long time, do you have any tricks or tips to help? Because sometimes with the oil, you can get kind of knots, or just with the soreness they can have when they're given injections for such a long time.
Yes. Okay. Tips and tricks. Intramuscular shots are the ones that people are afraid of because the length of the needle is scary. The length of the needle, just so you know, does not make the shot any more painful. The nerve cells on the surface of the skin are where you sense pain. So what you want to do to help with this actual shot pain, there's several things. You can ice the site ahead of time. As I said in the video, you can use a numbing cream like Emla cream. This is lidocaine. You can put about a quarter size smear on this where you're going to give the shot. Cover it with saran wrap, tape it down with paper tape, set yourself an alarm for 60 minutes. And then when it goes off, you just wipe it off with a wet washcloth, prep your skin with alcohol, and give your shot. This should numb the skin completely and you won't feel it. Another option is the Centerra Patch. Does the same thing, a little more expensive, but works like a dream. It only takes about 20 to 30 minutes to work. And Tickle Technique. So I think those are all great little tricks that you can try and see what works for you. And then another thing for the long-term soreness, now Delestrogen isn't something that you typically have a lot of long-term soreness with because you're only giving it twice a week, and you can rotate hips left and right, back and forth. So you're not typically going to have that long-term soreness like you do with the progesterone and oil injections. But if you do tend to get some soreness, you can use a warm compress. I recommend putting rice in a long sock and tying a knot, putting it in the microwave for a minute or two till it's warm, and you can use that ball of rice to massage your site. And that heat, that moist heat, is going to bring more blood flow to the area and help that medication absorb a little bit better and have less knots, less long-term soreness. Another thing to just make sure you absolutely don't forget is that you do need to put that needle in all the way to the hub. Some people get scared and they don't want to put it in all the way, but you risk injecting that medication into the subcutaneous fat if you don't inject the needle all the way and get through that fat layer. If you inject the medication into the fat layer, it's going to cause a lot of pain. It can get really warm to the touch, a little cellulitis, and it's very, very painful if you do that. So do put that needle all the way in before you inject it.
There, today we're going to talk about progesterone in sesame oil injections. Progesterone is a medication that's used in most IVF cycles and many frozen embryo transfer cycles. And this is the medication that's actually going to help to support a pregnancy until your placenta takes over. And so this medication is very important. And this medication is also can tend to be somewhat daunting for some patients, in that it is one of the injections that will be administered intramuscularly. And the site for your intramuscular injections is going to be the upper outer quadrant of your butt. That is the only site that we recommend for these injections. Remember that this injection is mixed in sesame oil, which is a pretty thick substance. And so we always want to make sure that you're injecting it into the right spot. And most clinics across the board will advise you to administer this medication to the upper outer quadrant of your butt. So it's possible for you to have someone else administer this medication, but there's also lots of patients who end up doing these injections on their own and like the control of doing it on their own. So I can show you two ways for doing this injection, whether someone else is administering or whether you're going to be giving it to yourself. But the first thing you want to do when you're getting your progesterone injections ready, you're first going to need your vial of progesterone. And again, progesterone is mixed in sesame oil. This medication is not meant to be refrigerated. It is meant to be kept at room temperature. And you are also going to need a syringe. Usually your dose of progesterone might be 1 milliliter, but again, it depends on your clinic. Sometimes it's more, sometimes it's less. It's often patient specific. You're going to need an 18 gauge, 1.5 inch needle. That's going to be your mixing needle. And again, this needle, although it's big and thick, it is the best needle for drawing up progesterone because that progesterone is so thick that it does come out nicely with this big syringe, big needle. And then when it's time for your injection, you're going to change over to the 22 gauge, 1.5 inch needle. Now, this is the injection needle. A lot of people worry, why is it so big? Why is it so long? Do I really have to inject that whole syringe, that whole needle into my body? The answer is yes. The reason why the needle is as long as it is that it's not being injected into the subcutaneous tissue like some of your other medications were. This one actually needs to access the muscle, and that's where the progesterone is best absorbed. And so that is the reason for the length of this needle. And so the first thing you want to do is grab your vial of progesterone. And one thing to note about progesterone, it's actually a multi-use vial. Anytime you're dipping into a multi-use vial, multi-use means you're not going to use this vial for just one injection. It's actually going to be for several injections. You always want to clean the top of the vial with a little alcohol pad, and that just makes sure that you keep it clean, prevents infection. So you're going to pop the top off the cap, pop the cap off the top, rather, if this is the first time that you're doing these injections. The cap doesn't go back on. So that's part of the reason why you want to use the alcohol pads, because it's not going to be something that you can snap on and off. It comes off one time, and that rubber stopper prevents the liquid from coming out. And so you'll just always want to make sure you use an alcohol pad to clean it off every time you dip into it. So this is the first time I've opened up my vial of progesterone. I can use an alcohol pad just to be safe. Open up your alcohol swab, and you're going to clean off the top. So you'll want to get your syringe and needle ready. Sometimes they're connected and attached together, and sometimes they're not. This one is not. This is a 1 milliliter syringe here, and I'm going to attach it to the end of my 18 gauge, 1.5 inch needle. So I'm going to go ahead and show you how to drop 1 milliliter of mixing of the progesterone today. And again, your dose is going to be dependent on what your clinic advises you to do. So you're going to want to put your 18 gauge right into the top of that rubber stopper and flip the whole thing upside down. Pull back on the end of the plunger, and you should see your syringe start to fill up with liquid. Once you fill up Again, you can manipulate this, and sometimes it comes out slow. Again, it's oil, so don't expect for it to pull back as quickly as it might with some of your other mixing medications. But you can manipulate, you can push back on the plunger, you can pull back until you get exactly what you need. And you want to pull back until your rubber stopper, the top of your rubber stopper, lines up with the 1 milliliter mark. My syringe is continuing to fill up with the liquid. It's going pretty slowly, and that's okay. We'll let it continue filling up. Again, I'm going to keep manipulating it until I get exactly what I need. And once I have my 1 milliliter of progesterone, I'm going to be ready for my injection. I'm going to pull the needle out. Again, this is multi-use, so don't throw it away. You want to put it in a safe place. It is meant to be kept at room temperature. I'm going to safely put the cap back onto the end of my 18 gauge needle, and I'm going to remove it. And I'm going to put my 22 gauge 1.5 inch injection needle onto the end. So again, progesterone is meant to be administered to the upper outer quadrant of your butt. The timing of progesterone is pretty important. Your clinic might specify that you're meant to take your progesterone injections always in the morning or always in the evening. Usually they'll give you a 3 to 4 hour window for injection. It's important to try to stick within that window, just to make sure that you're keeping a steady stream of progesterone in your body. So upper outer quadrant of your butt, you're going to find your site markings. So if you put your hand on your hip and you drop your thumb about 1 inch to 1.5 inches, it is the very top most upper outer quadrant of your butt. Another way to visualize this is to kind of think about like where the tag on your jeans might be, and you would go all the way to one side or all the way to the other side. The new recommendations are that it should almost feel like it's going in your hip. You want to be avoiding the sciatic nerve, which runs right down the middle of each of your butt cheeks, and you don't want to hit that. That will be very painful. So you're going to go up and out of the way. You should be able to usually just glance over and see where those injections are going. And a really good thing to do is to ask your nurse to actually take a Sharpie, draw some circles on your butt, and that way you know you're going in the right spot each time. So if someone else is going to be administering this injection for you, again, you'll have your site already marked out, and it's a good idea. You want to stand up and you want to lean forward on a hard surface. And that way you can take the weight off of the leg and the butt cheek that you're injecting into. And that way it's not a tense muscle. So you're going to relax on that side. And the person who's doing the injection is going to, instead of pinching like we might with some of our other injections that are subcutaneous, now we want to spread the skin. So they're going to take their hands, they're going to spread the skin to stabilize it. And they're going to take the cap off the end. You can always use an alcohol pad to cleanse the site, again, or just soap and water. You're going to spread the site. The needle is going to go straight in all the way down to the hub. Once the needle is injected all the way, they can release this hand and use it to stabilize the syringe. Now what you want to do is you want to pull back a tiny bit on the plunger, checking for blood return. You just want to make sure you're not about to inject into a little vessel or something that might cause a big bruise. If you see your syringe fill up with blood, then you know you're in the wrong spot. You want to pull the whole thing out and you're going to inject into the opposite side. This, by the way, will not likely happen. Most patients, especially if you're going in the right spot, it's rare that your syringe would fill up with blood like that. And so assuming you don't see that, you're just going to go ahead and push straight in, push the liquid all the way in. Now, again, because this is mixed in oil, it doesn't go in as fast as some of the other injections might. And that's probably okay. You know, some patients don't want to have all of that oil pushed into the muscle, you know, in a really fast way. So it's fine if it just kind of goes in at the pace that it's going to go in. You can instruct the person that's doing your injection to either go faster or slower if possible. Once the injection is all the way in, there's no more medication to administer. You pull straight out. Again, put the safety cap back on the end so that you don't stab yourself. And you can separate the syringe from the needle. So not all of this has to go into the sharps container. The needle can be separated and this can be placed into the sharps container. And this is just regular trash. This can go into the regular trash can. Now, if you are going to be administering this injection yourself, I always recommend that you get someone, the nurse, preferably in your clinic, to go ahead and take a Sharpie, draw some circles on your butt. That way you know exactly where your injections are going. If you were to try to stand up and like use a mirror and try to figure out where this is going to go, you're going to be putting in all kinds of crazy places. So it's a better idea to sit down and cross your leg one over the other. And if you lean over and you look for your injection site. Again, you should be able to see it. You'll be able to see within the circle. You're just going to put the needle straight in, all the way in to the end of the plunger. And when you're using your dominant hand, you can actually go ahead and pull back a little bit on the plunger and check for blood return and inject. If it's ever with your non-dominant hand, sometimes it's hard to manipulate the plunger like that. So as long as you're going within the correct injection site, your chances of getting it wrong are slim to none. But it's really important. One thing to know is that you want to alternate each day. So you're going to go, on the right side one day and on the left side the next day, and go back and forth and back and forth. And that way you're not fatiguing that muscle. Another trick is to take your hand after you do the injection. You're going to massage the injection site, help that oil to really get into the muscle. Walking around for a little bit afterwards also gets the muscle moving and helps that medication to absorb. And a lot of patients will end up using a heating pad. So usually we recommend using heat rather than ice when you're trying to get the oil to absorb into the muscle. And so a heating pad, whether it's one that you plug into the wall and sit on for 20 minutes, or they even make those, those little heat packs that you kind of like snap and put on your butt and go about your life. Either way is totally fine, but it helps, really helps take the edge off and helps with that progesterone to absorb into the muscle. Progesterone is one of those medications that you're going to be on for kind of a long haul. Again, it's a really important injection. That medication is the lifeblood of the baby. And so you want to make sure that you're continuing it until your physician gives you instructions to stop taking it. Some clinics will even have you do a tapering of that medication, or some will just have you stop it altogether. It's all just dependent on the clinic, so just make sure you follow along with those instructions. Those are your instructions for mixing up progesterone, and best of luck on the journey.
Okay, beautiful. So the first question that I have is, you kind of touched base on it a little bit, but you that you're going to be on it for a while. But this patient said that she's heard that she's got knots from the progesterone oil from after her injections that are kind of hurting her. Any tips for those to help with those knots or this discomfort of the progesterone oil injection?
Yeah, so unfortunately, knots can be somewhat common, and some people are just kind of prone to them, and other patients will give 8 weeks of injections and you'd never know they ever put a needle in their butt. So it's kind of funny how patients can respond to this medication. But one of the things that you want to do, which I did talk about a little bit, the very first thing you want to do after you give your injection is just take your hand and massage the site. And that really helps to help that oil to thin out and get into the muscle. And then heat is also a really good option to kind of help that oil to thin out, and can also be helpful with knots. But one thing I will say, because my patients call me all the time, I've got a knot, and what should I do? I give them two options. Number one is to take a picture of their butt so that I can see their injection sites and make sure that they're going in the right spot, because more often than not, there's some wiggle room. If there's a big knot there, like maybe we can move an inch to the right or to the left or up or down, or, and kind of be able to get away from that knot so that it's not so painful. And the other option is to actually come into the clinic so that we can really reassess. We want to make sure that there's nothing else going on. And if it's just a knot because there's just oil buildup under the muscle, that's one thing. But if it's something else, we can certainly assess that into the clinic. And so it's just really important to, make sure that you're touching base with someone and knowing that you're going in the right spots. And we're always happy to redraw, Sharpie circles on your butt and make sure that you're given those injections in the right place, because we don't want you to be in pain and be uncomfortable from these, especially because you do have to take them for so long.
No, I think that's great. One thing I always tell my patients too is just making sure that they're putting their needle all the way in to where it hits the hub. Even though it's a bigger needle, it can be scary. Sometimes I feel like they don't go all the way in, and then that oil gets caught between the skin and the muscle, and that's what kind of can cause that too. And also, I think I always tell my patients do it in the morning and then take like a shower, like a heat pack, because really that warm compress or water will help kind of disperse that oil, which I know you can touch base on.
That's a good idea.
Yeah. Okay. Next question is, what should a patient do if she accidentally missed a dose of her progesterone oil?
Yeah, so this does happen. I get lots of panicky messages from patients who it like just gets away from them. My advice to patients, if my patients call me and ask me what to do, it's take it right away. Take your injection, whatever you're doing, stop what you're doing, take your injection. It's really important to not miss a dose. But of course, I would advise if you're not my patient, call your nurse and make sure that you touch base with your nurse or your doctor and let them know, they might have a different protocol to follow for that. But typically the answer is take it. Go ahead and take it regardless of what time it is, so that you can make sure you get that dose in.
No, great. Next question that we have is this the oil injections, is it better than a suppository? Is there a big difference? Some patients are on both of them. Can you kind of touch base on why a patient might be on oil versus the suppository, or what's your professional opinion on which one's better?
Yeah, so this is the debate. I start getting asked these questions before patients even start their treatment cycle. I think there's just a lot of anxiety around these intramuscular injections, and so number one, to address which is better. I think that there's a lot of what we do in the repro world that it's like, that's just what we've always done. Like, we're going to keep doing it this way because that's the way that it works. And that's the way that, we can swear by. And so a lot of times clinics will kind of use that reasoning as to why they want to do things. But anecdotally, what we find is that when patients are using the vaginal suppositories versus the intramuscular injections, that it does tend to actually cause more anxiety than you think it would. Number one, I find that patients, especially in early pregnancy, you kind of have these, cramping sensations in your uterus anyways, as the smooth muscle of your uterus grows and expands to accommodate the growing baby. And so sometimes when you're using vaginal suppositories, we find that, the half-life of that medication is a little bit shorter, and it can cause some more cramping, and it can also cause, cervical and vaginal irritation. And sometimes those patients might experience spotting, where spotting can often be normal in early pregnancy. This just kind of tends to exacerbate things. And so usually my advice to patients is to just try to stick it out with the intramuscular injections as long as possible. One of the other things that I notice that we're able to see is that the progesterone and oil, the injections, you can actually, give an injection and then get a readout when you draw someone's blood as to how they've absorbed and they're processing that medication. And so we, usually have a threshold as to, what's an appropriate progesterone number to see. And we don't often see that with the vaginal suppositories, only because they're absorbed right at the source rather than systemically. So someone might be having perfectly appropriate progesterone levels with the vaginal suppositories. It's just you can't see it when you're drawing their blood and checking their levels. And that can cause anxiety. People are freaking out, like they've been on these message boards and they know what an appropriate progesterone level is, and their number isn't there. And so sometimes, it can, you think you're kind of like, oh, well, I just want to do these injections and I just won't have to worry about it. But sometimes you're kind of adding in, more worry that's unnecessary. But I will speak also to patients who are on both. And I do find that there's, maybe a very small percentage of patients every year where we start them on the intramuscular injections, and that dose even sometimes will increase the dose, and we're still not seeing the numbers where we want them to be. And so we'll often use the vaginal suppositories as an adjunct. So, to help to supplement that. So they might take their intramuscular dose of progesterone in the morning and then use a suppository at night. That way they're not having to wait so long to get their next, kind of kick of progesterone, that they can help to keep a steadier stream of progesterone. And so some patients do use both.
No, that was great. Thanks for touching base on that. And then again, kind of goes back to our previous saying, is everyone is so different. Your physician may add things in or take things away, or you're going to be on it. So just know if you're type A, this is going to be kind of how to let go of some control. So thanks for touching base on that. Another question is how to store the progesterone oil. Fridge, out, leave it out. Or and also someone in the blog, they just wrote that they heard you can put the oil in hot water to thin out the oil, and if they could do that.
Yeah. So two parts to that question. Number one, how does one store progesterone and oil? So it's actually just meant to be stored at room temperature, so you can leave it out on your counter. You wouldn't put your olive oil in your refrigerator. You know, if you kind of think about, like, if you ever make fresh salad dressing or something and you put it in the refrigerator, when it comes out, it's like clumpy and it starts to separate, and you have to let it get to room temperature anyways. So always keep your progesterone and oil at room temperature. But yes, it's certainly possible to take that progesterone and oil, take that vial, and to put it in like a little tub of hot water. And that does help that progesterone and oil to thin out a little bit. Another thing that patients can do, especially if they just like, sometimes you're giving these shots in the morning and your day might start very early and you're like, I just don't have time to be putting things in, you know, hot water and waiting for the magic to happen. So just taking it and rubbing it between your hands a little bit back and forth can help to warm it up and thin it out and help to make that progesterone injection a little bit more palatable.
No, that's great. And then the last thing is, with the last question I see is there are different types of oil that progesterone can be put in. We discussed progesterone and sesame oil, but can you kind of touch base on the other oils, or if a patient why a patient might be on a different type of oil than the sesame oil?
Yeah. So there are different concoctions of progesterone. The standard is progesterone and sesame oil. It's the most readily available. It's usually the most cost effective. But some patients, and it's funny how it happens, because it's usually after repeated exposure to the progesterone and sesame oil that some patients will actually exhibit a site reaction to the sesame oil compound, and they'll call me and they'll be like, all of a sudden I've got this big welt at my injection site and it's itchy, and what can I do? And sometimes these patients will have done an entire IVF cycle and used it and had no problem, come back for baby number 2. And it's when they're doing their frozen embryo transfer cycle that they develop this reaction. So you can't always predict how it's going to happen. And so when that happens, what we can do is actually prescribe for you progesterone and ethyl oleate, which is just a different compound, doesn't use sesame, and most patients will actually do better than that. So conveniently, Mandell's will compound progesterone and ethyl oleate for you. So if this ever happens to you and you start to develop a site reaction, number one, you can just put something, topical hydrocortisone on there to help with the itching that you're having. Usually Benadryl is safe to take, but don't suffer through this. Let your team know so that they can send in a prescription for the progesterone and ethyl oleate if you need it.
Perfect. That was awesome. Okay, I don't think I have any other questions. Do you have anything else you want to talk about with any of the medications before I kind of close this out?
Yeah, I hope that this was helpful for everyone. I know that it's sometimes, even now as COVID restrictions are lifting and hopefully everybody's back in the clinic, so you just might not have that same FaceTime that you may have had in the past with your nursing team. And so I hope that this was helpful to be able to touch base with a human who does this and can help patients to navigate this journey. And so you guys will do great. I always tell my patients, as overwhelming as this is, we would not send you home with a big box of needles and syringes and say, good luck, hope for the best, if we didn't think you could do this. You can do this. Expect that your first night of medications is going to be drama. There's often, fumbling around and where does this go? And how do I do that? And oh my God, tears and all the things, totally normal. By the third night, you can have a dinner party and excuse yourself to go to the bathroom and mix up and administer your meds and come back 5 minutes later like it was no big thing. So you definitely got this.